head injuries, because there is always that chance, and in most cases it does happen where the plane bounces to and fro. So, for example, if it gets hit in the front, it bounces off the back wall. Much like a basketball, if I throw a soccer ball in the back wall, it's going to bounce and come back. If I throw it hard enough, it may hit the front wall, but I don't know if I'd have any luck in that. I was terrible at dodgeball, believe me. So we'll start with the case. Let me get that baby in. Here we go. This is an actual case that happened in Vermont when I was working there. This is a 27-year-old, and you can see just by the damage to the motorcycle what we're going to talk about. He was helmeted. He struck a tree, however. On arrival, he was somewhat sleepy. He didn't look like he was overtly injured anywhere else. It was just his inability to answer questions. He kept asking the same question over and over. Sign of a concussion for sure, closed head injury. He can't recall the day, the time. His neck hurts, and he has a lot of abrasions. But I'd like to draw your attention, as all us personnel know, we have hypotension with bradycardia, a little bit of tachypnea there. What do you think? Is he head injured or not? Pretty obvious, right? Yeah. I didn't know that until I did the slide now. All right, next slide. Thanks, Tom. So sure enough, this guy went on, if I remember right, I think he had a subdural. Can't remember what side. We shipped him to the University of Vermont. He did well. Went through rehab and so forth. But these are things to think about. We're going to go over some things to think about when you assess a head injured patient. First of all, and first and most important, always assume there's a head injury, unless it has no relevance to what you went for. Say, for example, you go and it's just a sprained ankle. They stepped down from the step, sprained their ankle, and they didn't fall, didn't have a head strike. We're pretty safe to assume that there's no head injury there. However, when you get called to an unresponsive, a patient with a syncopal episode, I fell out of bed, grandma may have fallen on the floor, don't know. There was an accident at the scene. The patient may be walking, they may be talking, but it's always safe to assume that there's a head injury until proven otherwise. All right. So our objective is to assume and define what a closed head injury is, understand how the injuries occur. I've already hinted to the counter-coup type of injury. I'll explain that a little bit more. How to approach the head injured patient and how to manage the head injured patient in the back of the truck there. And you guys, I don't expect you to have CP anytime soon on the back of the rig. That would be kind of fun, but doesn't happen that way. That's something we do. Whenever you come through, if you've dropped off a patient and you come back, you want to see their head CT at another time. If you come through, let me know. I can just bring it up on the monitor, because I keep the X-ray piece open as an open tab on my monitor. So you can come back and say, yeah, John Doe, we just brought in a few hours back. What did his CT look like? Sometimes, and a lot of times, the CTs are normal. They do not show bleeding. But even without hemorrhage, can a patient have a head injury? Absolutely. So head injuries don't always bleed, and all that bleeds is not a head injury. Patients can bleed from AVMs and from aneurysms just as much and have a stroke, but they have no head injury there. All right, Tom, next slide, please. So it's important for us to consider how to identify a head injury, to recognize that it can happen. We'll go through signs and symptoms for you. And one thing, as healthcare providers, we all need to keep an eye on preventing head injuries, because the more head injuries a person has, the more inclined they are to have post-concussive syndrome or complications with their ability to think, to reason, to walk, to do even ADLs like button a shirt, or to manage to eat correctly. They may end up with tremors, seizures, limping, that sort of thing. So it's pretty well defined now, and there's lots and lots of literature that's being published in the last decade on this whole post-concussive thing. It really came to light with the Afghan Afghanistan conflict and coming out of the Iraqi war. So many soldiers were coming back with these signs and symptoms of having been concussed from explosives and thrown from their Humvees and so forth. And they were identifying all these long sequelae, dysrhythmias even, frequent headaches, mood changes, stumbling around, speech trouble, cognition trouble. All that happens with cumulative effect of damage on the head. So whatever we can do to prevent things. I know all of us are responders. We respond to the 911 calls, but many of us are asked to teach at times, especially in schools, senior centers, and that sort of thing. So it's really good when you're asked to talk about concussions in sports or just head injuries in general, to mention that, to do things to prevent head injuries, the appropriate helmet applications, to use aids for walking, to hold the rails when you're going down the stairs, and so forth. I have to confess, I don't always hold the handrail going down the stairs. Okay, don't forget, there's something that attaches the head to the body right here, and that's the C-spine. I have to say that all of the services that supply our patients are pretty darn good at applying seat collars when appropriate. I really appreciate that. Even if it's a towel roll because you can't fit the collar very well, something's better than nothing to keep the neck as immobile as possible, because with a head injury, what's very vulnerable to injury? The C-spine. And patients can have a ligamentous injury and no bony injury. So we're not always protecting them from a fracture, we're protecting them from ligament injury too. And there's a good 5 ligaments, if not more, that hold the C-spine together. And those ligaments can get torn pretty easy. Thanks, Tom. Definitions kind of get bored, but these are the most accurate and up-to-date based on my little research. Mild traumatic injury or brain injury is TBI. Everybody knows that terminology or acronym. It's a head injury due to contact or the acceleration-deceleration injury. Classic is motor vehicle accident. I'm driving, let's say I'm driving down Route 2. I'm going pretty fast. Someone just suddenly brakes in front of me, and I don't brake in time. I hit the back of their vehicle and do one of these lunges. I have my seatbelt on, airbag goes off, but my head has done one of these, back and forth things. That can even happen at the local fair, with the roller coaster ride, swings, whatever it is, that sudden acceleration, deceleration type of thing. So we have mild, moderate, and severe Glasgow scoring. Everybody's familiar with the Glasgow Coma Scale, right? We all use it. Interesting history, it was named that way because of the city where it was first developed, of course, Glasgow, Scotland. Well, thanks, guys. You'll get credit. Yeah, so the Glasgow scale was developed in the university, Glasgow University, and that's how it was named. So mild brain injury is the somewhat dazed, kind of repetitive, or the sleepy patient. Hey Dan, how are you? Oh, I'm fine. I'll be okay. And they fall asleep again. Kind of like when you first wake up in the morning, you're awake but you're not, and you need some coffee. That's between 13 and 15. A score of 9 to 12 is a little bit more severe. That's called moderate. That's the patient that is hard to arouse, the patient with repetitive questioning, the patient with a little amnesia, either before the event or after the event happened. Before the event is anterograde, A-N-T-E-R-O, anterograde. Post-event is retrograde. So let's say, for example, a patient's in a head injury, car accident. You score them at a Glasgow of around 9. They can remember that they were going to the grocery store, but everything thereafter, they just have no clue. They don't know where they are, who picked them up. They weren't aware of the ambulance ride and so forth. That's retrograde amnesia. The International Conference of Concussion in Sports, as recently as 2012, I think it's every 12 years, 10 years. So they may have met already, and I don't have any more recent literature to tell you. I'm kind of bad on that, I'm sorry. But anyway, the consensus of a concussion, and this is still accepted, is this. It's a brain injury defined as a complex pathophysiological process affecting the brain, and it's induced by trauma, biochemical changes that happen from trauma. Okay, this is not, concussion is not a definition that we see medically. For example, if a patient has a stroke and they lose their ability to think, to reason, that's not a concussion by definition. Okay, that is memory loss secondary to a stroke, a whole different mechanism. Whereby as trauma, got hit with a ball bat, I had forward acceleration, deceleration. Now I fell down a flight of stairs. That's concussion by definition. Thanks, Tom. Concussion is a direct blow. That's I'm warming up on the ball field, and someone behind me is practicing his swing, got too close and clubbed me in the back of the head. That can happen. Or some other direct blow to the force of the head. Maybe even an assault where there's an argument and the perpetrator pushes the patient back into a wall and the patient head strikes the wall. I took care of a school teacher not too long ago that one of her students assaulted her. He's a special needs child, and she wrapped her head against the wall. Typically, a concussion is a rapid onset of neurological symptoms. That's very helpful for you as an assessor in the scene, right? So, for example, you think there may be a head injury. The friend or the family member thinks they may have hit their head. But when you start asking them and doing a history, they've been kind of in and out of it and confused for the last 3 days. That's not a concussion by definition. Now, they may have hit their head, but maybe this last 3 days has nothing to do with what you're seeing there. There may be something else going on, okay? So concussion happens rather rapidly. They were fine when they went to football practice. Then after the tackle in the field, just 10 minutes ago, they're really weird. They're asking the same question over and over again. Sudden change in their behavior or how they're functioning. Their speech is slurry. They're not speaking words right. They may have the expressive aphasia, where you ask them their name and they say, "Oh, it was Tuesday." They don't answer appropriately at all. So, kind of like when the nurses ask me a question and I'm totally dumped. It happens a lot. Functional disturbance, that's another one. I'm sorry, these are highlighted in black, so I don't know if you can see them very well. But there's a functional disturbance rather than a structural injury. So many times the patients have a closed head injury and we can't see. We can't see a wound. We can't see a hematoma. We can't see anything wrong with the pupils. There's no blood coming out of the nose or the ears. Their jaw is in nice alignment. They're speaking normally, so you can't see the injury. But what we see on a CAT scan is much different. We may see swelling, edema, bleeding. So it's something functional. That's why it's so important to assess the patient with the coma scale and what they can say and so forth. We'll be talking about that. So this involves a clinical syndrome. It's not hard and fast science. So many times when you go to the scene, if they have cut themselves, you can see the laceration. If they have a fracture dislocation in the ankle, you can visibly see it, right? But many times in medicine as well as in trauma, we can't see the injury, right? Which leads me to that soapbox thing. When you go to a trauma patient or a medical patient for that matter, remember it's ABCDEs first, right? No matter how straightforward, no matter how simple, always go through that because you don't want to miss anything. Next slide. Okay, this is interesting data. Just squared away. 1.7 million people sustain a TBI every year, and it may be higher than that now. Pretty sad, and it's both veterans and military people as well as lay people and civilians. Motor vehicle accidents are a good chunk of that, up to around 45%. Even with all the safety devices, you and I both know and have seen how many motor vehicle accidents, despite seatbelts and airbags, they still get heavy-duty injuries. Just depends on the speed and the mechanism. Falls are about 38%, and many people fall. If I'm talking too loud, just let me know. But many people fall, and how many nursing homes and group homes do we have around us? How many assisted living places? These people are very, very prone to falls. So we got to keep an eye out for that. Don't forget that occupations attract about 10% of falls. Recreation, all those fun things we do, waterboarding or skydiving, or all those fun things to do on weekends. Don't forget that assaults are on the rise. Unfortunately, people are becoming more and more aggressive, violent, angry. I think a lot of it, I blame COVID for that, but because it seemed to accelerate, right as we were coming out of the pandemic. You take the whole population of the world and confine them for a while, and then you deconfine them, if that's a word, everybody explodes, so that might be part of it. Obviously, this everybody knows, falls are more common in the elderly for a myriad of reasons. That's osteoporosis, it's structural, it can be physiologic, it can even be psychiatric, or you just feel very alone and isolated and decide to do things on their own. So contact sports, we've mentioned that already, as high as 20%. And that's why I picked this topic for tonight, because we're starting school, or have started school. So we're going to see this. And I'm sure all of us in the room have gotten called on athletes in the field, on the basketball court, on the ice rink, wherever it may be. I had a lady, a girl actually, in Apple, 14 years old, just hit in the head with a spiked volleyball. And she was concussed because she was right near the net. She and her team, she was on the JV squad, the varsity squad was warming up. The JV squad was assigned to just pick up the balls. So she's standing like from here to the pole, and her varsity cohort just spiked the ball and hit her right smack in the left side of her head. So it can happen. And volleyballs are inflated to the max, of course. Soldiers, that goes without saying. Next slide. So this is that coup, counter coup injury. Interesting history again. I'm into words. So coup and counter coup actually means, it's French word. It means fight or embattlement. So when you hear the coup d'etat, that's where rebels or some military force overtakes the government. That's what that means. But a coup injury in medicine is the direct injury. The counter coup is the opposite. So this diagram or picture shows that the coup injury took place on the right side, looks like around the parietal area of the head here. And then when the brain bounced back or the head bounces back, they get a counter coup on the opposite side. It's a wham bang. So don't forget that the patients can be duly injured just from a simple head travel back and forth. And for those that are in higher speed accidents, that can be a real deal. And it's not something you may see right away. You may notice at the scene, they've got a GCS of 15. By the time they hit my door, they're down around a 13. So things can progress. So don't beat yourself up if when you call back in for another assessment, or you get contacted by the hospital or the doctor, the nurse, or whatever, and they say, John Doe that you brought in, he slipped into a coma, we had to transfer. That can happen all the time. No fault of your own, it's just natural progression of disease. Next slide, Tom. So this is what happens down at the physiological level. I like to tell you that you guys are clinicians, you are not technicians. In my definition, in my book, emergency care begins with you and the police department, of course. And that's where it starts. You are the thinkers, you bring the caseload to me, and then I pick it up from there. So I want you to kind of think like I would. How does this take place? What happens physiologically? The nerves in the brain and in the spinal cord are what we call axons. This is a diagram of what it looks like. This is the cell body. These are dendrites that are coming out, and this is called the axon. And all the axon are these cells that are surrounded by a cell membrane, largely loaded with protoplasm or cell fluid. And in that fluid are neurotransmitters. Those are things like dopamine, norepinephrine, sound familiar? We use them for pressors. Serotonin's in there, and a few other ones. The signal is started in the cell and goes down the axon. But unfortunately, with that coup, counter coup, or even that sudden thrust of the brain, these axons can get damaged. So the arrow, where the arrow is showing you an axonal ending where the damage can take place. What happens to the nerve signal then if the axon gets damaged? Yeah, that's a good way to describe it. I don't know how to spell that word, but yeah, there's no signal there. So no signal means no function. Now, is this a motor cell? And that means maybe their motor movement is, they can't move their leg. Is it a sensory cell? They're numb or tingling. Is it a cell that goes to the speech compartment and broke a speech area on the left side of the brain? Then they can't talk right. Is it a memory cell? They're losing their short-term memory. They can't remember what their name is or their date of birth or their address. So this is a rupture or a disruption, a shearing force of the axon, and it disrupts all these neurotransmitters that happen, and then they get depleted. Sometimes, too, interesting, these neurotransmitters can build up in the soft tissues, and then we have overflow of dopamine, overflow of epinephrine, and so forth. So now we see signs and symptoms that match what's going on. Hence, the bradycardia and the hypertension you see with brain injury, right? Because those neurotransmitters are leaking out, it drops the blood pressure, it causes vasodilation, etc. Kind of a neat reflex. It's called Cushing's reflex. You remember that from your story? Cushing's reflex is just the opposite. In shock, all of us know that shock, your blood pressure goes down and your heart rate goes up, right? Normal reflex in hemorrhagic shock, hypovolemic shock. But in septic shock or neurogenic shock, which is more distributive across the entire body, guess what happens? You drop your blood pressure, but you can also drop your heart rate. Okay? So keep that in mind, and that's what happened with the motorcyclists too. That next slide, top one. Oh my, we can all relax now. All right. So the types of brain injury that can happen, and this is primary brain injury. This is direct. You can have a diffuse brain injury. That's called diffuse axonal injury, DAI. That's where all the brain just gets these shearing forces and all the axons get disrupted. Diffuse axonal injury can be temporary, fortunately. Sometimes it takes a day or two, maybe a week or more for that all to resolve. Nerve tissue is the slowest growing tissue of the body. So that's why it takes so long for nerve damage to repair itself. Whether it's nerve damage from an amputation or nerve damage from a stroke or nerve damage from a concussion, it takes a long time to heal. By the way, does anybody know what the fastest healing tissue in the body is? Yeah, I'll give you a hint. I see. It's the cornea. The cornea is fast as healing. You get a corneal abrasion today, it'll be healed by Wednesday. Pretty cool. It hurts like the Dickens, but you get it right. Brain concussion, by definition, if it's it can be less than 6 hours, but a DAI is by definition greater than 6 hours. So that patient is concussed and they remain that way. You guys won't know that because the patient will either be discharged or admitted or transferred from our department. So if I send them to UMass and they're up in the neuro unit and they're there tomorrow and the next day because they're still out of it, they're still talking nonsense, and they have the DAI. One of the cases I'll reviewed for you ended up like this. Focal brain injury, on the other hand, is that which we're more familiar with. That's the brain bleed or the bruise on the brain. They can either be a cerebral edema or subdural or subarachnoid hemorrhage. Okay, and those patients are really injured. Underneath in parentheses, I wrote the mechanism for you. This is where the meningeal artery, that's an epidural, and the meninges is that layer in between the arachnoid layer and the dura, is right there. That's where all the blood vessels like to live. That's where the veins live. So if the meninges gets injured, you get a venous bleed, and that's what we call an epidural hematoma. And they always look like the moon, like a crescent shape on the CT scan. Well, not always, but most of the time. Medicine's like that, and your patients don't read the book. Have you ever noticed that? It's frustrating as all get out. We train A, B, C, D, and you go to the apartment, and they're doing X. It's like, you can do this. Subdurals are bridging veins. These are veins that cross over territory, and they cause bleeding in the dural space, which is right underneath that layer on the brain I was telling you about. Subdural have more of a convex look on a 3D than that crescent shape. I leave that up to the radiologist to do the interpretation for me. Intracerebral bleeds are that, intra meaning inside, cerebral meaning brain. That's the brain bleed inside. Now we see this even with no trauma. This is aneurysmal bleed. So the circle of Willis, it's inside the brain from the carotids, and then it goes out to the anterior cerebral artery, middle cerebral artery, and the posterior cerebral artery that we talked about last time with stroke. That's where bleeding takes place with aneurysms most of the time. Next slide. So this is what an epidural looks like. Pretty cool, huh? See, there's the dura I was telling you about. It's epi, meaning above the dura, and underneath the lining of the skull there. So that's an unhappy brain. These are often more trauma than anything else. So we'll see this a lot. Next slide. This is a subdural, and you notice it's more of a convexity. It's underneath the dura. This is the dura lining on the brain. It goes out and then it dips down here where the falx, that's the falx cerebri there. And then this is the subdural. The neuroanatomy was a whole semester in that school. I expected it. And it was eccentric headache number 101 through 2000. I got an A in neuroanatomy. I don't know how. It was really cool stuff. 5 days a week for one semester of nothing but lab and definitions and so forth. Next slide, Tom. This is an intracerebral blade, and this is what the CAT scan looks like. See how it's inside the cerebellum? Now, this is an interesting picture. What do you see in the midline? Bad. Yeah, that's called bad. That's right. That's a shift, and what we call a midline shift. If a patient has a midline shift, they're in deep trouble. The midline shift in the field that you may see is a pupil difference. One pupil will be dilated, one won't. Pupil will not be reactive to light. And remember, ladies and gentlemen, that pupil is almost the last thing to go. So if you see pupil problems, it's not a good thing. It's like end stage type of deal. Does that mean the patient will die? Probably, but not always. There's still some rescue time. So there's still time for us to act. A lot of times, if they're in real trouble, neurosurgeons will go in and drain this. So we don't do boreholes at Haywood, by the way. Next slide. So the second, you've seen primary injury. The primary injury to the brain is that direct blow or that counter-coup injury. These are secondary things. This you're going to see in the field. I don't expect you to come and call on the radio and say, Haywood, this is, I don't know, PA2. This is a subdural hematoma on the right. It is 7 centimeters in diameter, and I think we should go to UMass. And, since when you're telling me it's a subdural field? You will be telling me this is a 69-year-old female with osteoporosis who was coming down the stairs, had some back spasm, fell down the landing, from the landing to the living room floor, 5 steps, and she's got a SAT of 78. Her blood pressure is 94/60. Was through in another abnormality, and she had a witness seizure. So those are things you can see that your witness or your family member or witness to the patient can tell you. Those are things you can tell me, and between you and me, we can come up with, I think this patient had a head injury. And she probably had a lot of other things too. Who knows? Maybe she broke her back. That was a fracture. Maybe she had a stress fracture coming down the stairs. Boom. Maybe she started the seizure coming down the stairs. Maybe her sugar was low coming down the stairs. Maybe we don't know. Maybe Dan's making this up. So these are things that we can find. These are things that we find in the ER, or if you have point of care in the ambulance, all of us have point of care glucose. So if the patient has a sugar of 38 and they fell and bopped their head, they probably fell because they got hypoglycemic. Many times patients that are hypoglycemic aren't in the right mind, correct? So how many of us, when we're super hungry, aren't in the right mind? We get angry. Yeah, maybe that's part of it. So, you know what? Next time I should bring donuts and drink for everybody, shouldn't I? How bad a director am I not to feed you guys? That's terrible. So, we can detect this in the emergency department. So, two of the most important predictors, and that's why I highlighted this, for a patient's mortality rate, is hypoxemia and hypotension. If you see that on the field, I want you to take immediate action and correct that as much as you can. So hypoxemia is easy to fix, right? For the most part, that's simple oxygen. Dan, do I go all the way with this? Is it 100% non-rebreather? Could be, just depends on your reading, right? If they have a pulse ox of 78, you put on a nasal cannula at 2 liters and they go up to 94, you're sailing. If they're 78, you put on 2 liters, they go up to 81. You go up to 6 liters, they go up to 86. You take the next step, right? And if they're not breathing at all, I think it's time for compressions in the lucus, right? Okay. So hypotension, you know how to treat that, right? First thing you do for hypotension is IV and fluids, right? Does it hurt to give fluids to anybody with hypertension in a trauma patient? Probably not. You know, there might be some golden Jaegers out there that argue, but I can't see it. So even if the patient sounds wet to you, if they're in shock, the first treatment of shock is fluids. And then after fluids, the next treatment of shock would probably be blood in most cases, unless you know for darn for sure for certain it's neurogenic shock or septic shock. And even then, and a lot of us, of course, in the room are not giving blood in the field, at least yet. Next slide. We'll give blood in the ER. So hallmark symptoms in this we all know, but I'm reviewing them so everybody's on the same page. We look at confusion and amnesia. I've already alluded to that. Okay. If the confusion clears with a cup of coffee, that's not concussion. That's called morning wake up. That's Dan. If the amnesia and the confusion persist, we got some trouble. Almost always the amnesia involves a loss of memory for the event. Can you tell me what happened? And the patient will probably tell you no. Okay. Johnny come lately, the 16-year-old on the field, linebacker for the Tigers, and he gets hit hard, and he's down in the field, and he's noted not to get up when the rest of his team gets up. So the referee calls time. Everybody runs out to his aid. He wakes up, and do you remember what happened? I know. What's the last thing you remember? I'm putting my gear on in the locker room. Uh-oh, we've got a problem, right? Because now we're into the second quarter of the game, and you should remember all that. Okay? It frequently includes the loss of recall for the events either before or after. I've already defined those for you. You either have anterograde or retrograde amnesia. Kind of nice words to put in your run report if you want to sound smart. And when you're doing your run report. Keep in mind that the majority of concussions in sports do not cause loss of consciousness. So don't rule out concussion just because Johnny got hit and he's wide awake. He may remember the hit. He may remember that he's a linebacker, and he remembers the score. He remembers it was third down, and it was 3rd and 1, and they were going to the first down, and boom. So that doesn't rule out a concussion, does it? But what would rule in a concussion? I've got a headache. I don't feel good. I'm nauseated. You take him off to the sidelines on the bench. He threw up once. Okay? He's starting to ask some funny questions. So as time wears on, his memory is just a little bit off. You do the finger and nose thing, and he's going like this. He's a little off balance. So keep in mind, concussions can occur. Next slide, Tom. Without LOC. What else are you going to see? You know, that blank stare. That's the stare you give your significant other, your spouse, when they ask you if you got a certain task done. And it's like, Dan, did you take the garbage out? It's that blank stare. My wife knows it well. You didn't take the trash out, did you? Now I have that befuddled expression. Delayed verbal response. Can you tell me the date? And I have to think about it for a little bit. Okay. Can you tell me where we are? We're in Los Angeles. Okay. They're totally disoriented. Slurred speech, seizures, obviously, after a head injury, not a good thing. That would imply that there's axonal damage and you've hurt the axons and you've fired up the nerve tissue. The nerve tissue gets really jumpy and they can seize. Okay. So any of these, and you're all familiar with all these signs, right? I'm sure all of us in the room have seen these And this is an interesting one. Patients with concussion often are emotionally labile. So they cry just for no reason, or they get angry, or they lash out, or they're just flat affect, just super flat. And well, that's not right. Usually Susie's much more laughable. She's the jokester of the class. And now that she fell in the volleyball court, she's not herself. And a lot of times the witnesses, the family members will tell you that. This is not her. Have you all heard that, right? This is not her. This is not him. This is weird. Okay, next slide. Do you like my decor? I like pulling those out. It's a lot of fun. Neurological deterioration is highly suggestive of an evolving hematoma. That's why reassessments are so important in the back of the rib. I assessed them on the court. I assessed them on the stretcher after we loaded them in the truck. I assessed them right before the radio. If you have time, obviously, if your run time to the hospital is 3 minutes, your assessment is just times 1. That's all you have time for. But if you're out in the throes of Hubbardston, or you're assisting Apple with a run, maybe you're running a patient towards Haywood for a standard transfer, you get called for an assist because something's happened to the back of the rib, they're deteriorating. Maybe there's a game at the high school. And now the patient is starting to repeat questions. Now the patient is seizing, for example. We've got trouble on our hands. That's bad. Okay? Next slide. In fact, you could apply that rule in any medical emergency or trauma emergency. If the patient is deteriorating, if their vital signs are changing in the wrong direction, we've got something going on there. And it's up to us to look for what that something wrong is, right? Are we always going to identify that something wrong? Nope, afraid not. Even in the emergency department, there's lots of times where a patient will deteriorate, and it's like I'm digging the barrel trying to find out why. Why all of a sudden are they tachycardic? Why are they throwing PACs? Why is my patient with shortness of breath all of a sudden throwing 6 seconds of wide complex tachycardia and giving Dan sinus tachycardia? No. Found out he missed his last 2 doses of antiodral. Ding, yeah. That was fun. That was the other day. So these are your assessment questions. You guys know these well. Was there a blow to the head? And if the answer is no, does that rule it out? Not necessarily. But if the answer yes, that makes it a little easier. Were they wearing protective equipment? During a sports event, they may not always have a helmet on. Like volleyball, for instance. How many volleyball players wear helmets? 0. Even in the Olympic Games, they don't wear helmets. How about gymnasts? When they're doing the super duper flying through the air on the mat, that's one of my favorite events to watch in the Olympic Games, is to watch Simone just dance across that mat or do balance beam with the bars. It's just incredible how dangerous that really is, because if they take a fall, and they could be cooked. So always ABC, do your assessment of the and always immobilize that spine. Look for life threats too. Don't forget, the body is attached to itself. Head and neck are attached to trunk. Trunk is attached to the pelvis. Sounds like the hip bone's connected to the leg bone. You knew I was going there, didn't you? Okay, next slide. Yeah, you guys know me well. I'm stupid jokes and all those silly things. This is a reproduction of the Coma scale. All of us know it. I can tell you for sure, for certain, I do not have this well memorized. I usually do kind of an assessment in my head and then have to look up on the table to do the actual score. So I cheat a little bit. That's not cheating in my book. That's called being a smart clinician. I don't expect any of us in the room to remember everything about everything. We're human beings. We just don't remember everything. So I don't expect you guys to calculate a heart score. I don't expect you to rule in or rule out P-current criteria for a child with a head injury, or to do all these fancy calculations. That's what we have, apps for on our phone, or little cards in your pocket. Next slide. But it's nice to have this calculated. So these are questions you ask. What is your name? Tell me what happened. Where are you now? Where do you live? What is your birthday? These will help. Some of these are short-term memory questions. Some of them are longer-term. Who the president of the United States is, what year is it, what special event we have in Paris in July, When's what big events coming up in November, things like that. When's your birthday? Did you have a birthday party and so forth? Okay. A lot of the times in sports, it's good to ask them who you're playing because you may know. You look up at the scoreboard and it's Gardner playing I don't know who, maybe next town over. Yeah. I don't know. Gardner and Ethel, are they in the same league? Yeah. Okay. But anyway, who are you playing against? You look at the board, they give you the wrong answer. Oh, we're playing Duke University. So verify that answer because a lot of times they'll give you a birthday and that be totally wrong. They'll say 3/6/1970. Parents will go, oh no, they were born April 6, 1972. So it's good to know. Next slide. So have they had a history of concussions? If the answer is yes, all the more reason to get them to the hospital. Don't let them sign off if you can avoid it. If they're still insisting, obviously if it's a minor, that's easy. You can talk to the parents. If it's an adult though, they keep insisting, I would recommend a phone call or a radio call and ask me about it. Do our best to get them, because multiple concussions can lead TBI and it's important to get it treated. Now, am I going to do anything in the emergency department for a concussion? There's no pill for that. There's no potion, there's no IV, whatever. But I can get them into physical therapy to get them treated for their concussion for TBI, to get them cognitive training. That's CBT or cognitive behavioral therapy. It does help and decrease the amount of complications they have down the road. So anytime you see that, you should bring them in. What about second impact syndrome? What about the nausea, the complications, double vision, that sort of thing? That's important to transport. Yeah, next slide. These are tools that we use. Are you any of you familiar with this Westmead post-traumatic assessment? I've given this talk before to EMS, and no one was familiar with it, and I have to look it up. It's not one I use, but just for fun, just to let you know that there are other tools out there that neuropsychiatrists use. Also, therapists that specialize in brain injury use this scale too. It's just a scale of the amnesia and how bad it is. It just gives us an idea of where the patient is and how much treatment they'll need down the road. Okay, next slide. So this is just for kicks and giggles, just so you're familiar with it. It makes you sound smart when you talk to anybody. And for those of your colleagues that couldn't make it tonight, throw this at them and say, we're going to be using this now, and make them really scared for a little bit. It's like, oh, what? I missed that. Tell me all about it. You guys you asked these questions already, right? Right? Am I right? What's your name? What month are we in? What year are we in? Your birth date and so forth. So all these are part of that scale. So you're doing it already. You just didn't know you were doing it. So it's pretty cool. And we often don't do this because I don't know about you, but when you're riding in the ambulance, pull out 3 pictures. And on my phone, here, let me show you pictures of my grandchildren. And I'm like, hey, this is my dog. And it's like, no, don't do that. How long did your assessment take? Oh, an hour and a half before we transported the patient. We were sharing pictures. All right, next slide. All right, how do we manage a concussed or head injured patient? Simple. Everybody knows ABCDE. Airway is so important. If you skip airway and you bring in a head injured patient with a pulse ox of 78 and you have not addressed it, I will spank you. Okay. No, and I know all of you do that. If they have a pulse ox of 78, it's the first thing you address, right? Or if they look gray or cyanotic or just out of it, that's oxygen. And along with A becomes D-spine. If you're suspicious of a head injury and you can't clear that spine because they're concussed, confused, they have a distracting injury, all bets are off, right? Everybody uses the Nexus criteria and can't clear that spine. So even though some of these nurses bark, when they come in with the seat collar, put it on anyway, let us worry about it. Okay, next slide. Oh, yeah.
Sorry, I accidentally hit the wrong button.
Yeah, no problem. Okay, now this is an interesting fact. If they are hypocarbic, or hypercarbic, that can lead to worsening condition. So what I'm telling you is that end-tidal CO2 monitoring is a real good thing in a head injury patient. And I would applaud you for using that device when you're transporting a patient that has a suspected or a known head injury. To put that on there, it's good to know what their CO2 is. We want them around 35, give or take. That's a nice number, because if they get overly hypercarbon, what does too much CO2 do to the brain? Your cognition. It puts you to sleep, right, or makes you confused. Everybody's seen that the lung patient that retains CO2, they get really out of it and confused. Likewise, if it's too low, there again, they can really get into trouble too. So be careful that we normal ventilate these patients, not hyper or hypoventilate them, because we can induce a lot of trouble there.
All right, how bad?
I'm going to ask you to read all the slides really quick. Okay. Yeah, next slide. Okay. The H's and the T's, you guys know those for heart, but when it comes to head injury patients, pay attention to the blood pressure. Is it hyper or hypotensive? Is a head injury patient with a blood pressure of 212 over 180 a good thing? Not so. All right. Would you be able to treat hypertension in a head injury patient? You can, if it, I don't think it's in your proposal. You'd have to radio in on that one. Then I've got a pressure of 212 over whatever, and their head injury. Would it be safe to administer nitroglycerin? What happens if they got a bleed up there and I vasodilate all those arteries and veins? Are they going to bleed more? Yep. So kind of bets are off. There may or may not be an indication for me to use hydralazine or low pressure once they get there, but that's after a CAT scan. So I've got the advantage of imaging before I give the drug. So you're very right. No med is good med. So that's a good caveat for all of us, me included. No intervention is just as safe, if not safer in most cases, than intervening. We don't always have to do something. Okay. Next slide. If they're with a fever of 103, obviously that can be treated. A little Tylenol goes a long way. If we have it in the truck or have it available, it's really a good thing. Passive cooling, putting them in ice. So, for instance, if a patient has been running in a marathon in the summertime and they're overheated and they collapse from heat exhaustion or heat stroke, strike their head, so they're head injured and they've got heat stroke. They've got a temperature of 103, they're out of it, they had a witnessed brief seizure, you treat them. You treat them by reducing their temperature. Okay. Hypothermia, same way. They're out ice fishing. They had a few drinks before they start ice fishing. They take a plunge in the water, hit their head on the way in, they get out. They're hypothermic and head injured. You want to warn them out. Just an example. Treat the sugar. Next slide. How about fluids reset? What kind of fluids would we use in a patient that's hypotensive? Easy. Yeah. Right. Yeah. So we would use isotonic fluids, right? You would not use D5 in now. We don't even carry it on the trucks and I don't think. And we certainly would use normal saline. There's always that debate: is it LR or is it normal saline? There are a few exceptions where LR is the fluid of choice over saline, Burns being one of them, but that's not so much a word for you as it is for me, once the patient's in the department. In any event, whatever isotonic fluid that you can give them to raise that blood pressure is perfectly safe to do, okay? You want to make sure that you get a good line and do that. How do you treat a seizure with an injured patient? Any different than you would a medical seizure? Nope. Given the benzo, so it's either lorazepam or Dadalam most of the time, or you just ignore it, walk away, and say, "I'm done with this. I'm going to quit my job." Don't do that. Okay, next slide. Okay, statewide protocols in Mass is 4.4. I did that on purpose to look it up. You guys know this by heart. You want to prevent too much oxygen, too little oxygen, too much or too little CO2. Treat the sugar. Guard against seizures, the usual. You know, this is nothing new. Should be easy. Next slide. Right? And hyperventilation should only be used for short periods of time. Remember, they used to preach that to us all the time to hyperventilate.
Was
By
to
doing
promote,
that, we blow off the CO2. But that's been studied and it's not as effective as we thought, and it can do more harm than good. So it's good to normal ventilate. So our normal respiratory rate is around what, 10, 15 breaths per minute, give or take. So that's where you want to aim. And you want to aim not so much for the number of ventilations as you do the end tidal. You want to keep the end tidal CO2 pretty good.
there are still some schools that thought about keeping it, your end tidal in the low range of normal
Yeah, right.
to kind of promote the vasoconstriction without causing the
Very, yeah,
the compromise of circulation everywhere else.
That's right. Yeah, remember, medicine isn't a perfect science. So if you guys don't get it perfect right away, you know, that's no sweat. So next one. There you go. No, it doesn't have a specific name on it. So it could be any of them. C-spine precautions, obviously I preached that enough. If the mechanism of injury indicates that they need a little bit more than that, fine. If you feel in your judgment that patient needs air transport to a level 3 facility, by all means, I won't stop you. So if you call mid flight or light flight or any flight, that's fine. JetBlue, could you right now? So get them to the safest place possible. Time is against us, isn't it? It's awfully difficult to make a split decision in a matter of a minute or two. And sometimes that decision, when you look at it with the retrospectroscope, wasn't the best, but maybe at the time it was the best. But don't beat yourself up. If you bring a patient to the ER and they should have been somewhere else, it doesn't matter. What matters is they got good care as fast as possible. Okay? So I won't beat you up for bringing in a trauma patient. Private vehicle. Boy, that enters into a sticky wicket, right? You're at the high school, it's a basketball game. Two guys went for the ball at the same time, and you know what happens at the hoop. Bang! They hit their heads and both of them drop. One gets up, kind of rushes it off, and then goes to the sideline. The other one lays there, vomits once, and of course everybody's running out to the court to see what's going on. He ends up being cleaned up, wakes up, not so bad. His dad insists on bringing him to the hospital as well. I really want to go to St. Vincent's because that's where we live. We live down on Summer Street. We could walk to the hospital. I don't know. Playing in Gardner, I really think he was head injured enough and he had a concussion by definition, right? Brief loss of consciousness, a neurological symptom, immediate. Vitals are okay, but I'm a little concerned. This is a young 16-year-old, and now his heart rate is starting to get a little sloppy low, maybe 60, 58. Oh, but he's an athlete. I'll take him in my car. So there's a decision we all have to make, and sometimes if you want to share that decision with me, you can do that. If it's like I fell down, bumped my head, Granny gets back up and she's fine. Family's going to watch her. We'll take her to the hospital. If she gets worse, and you can sign that off. But use your judgment. So sometimes that's not a good thing, and sometimes it is a good thing. All right, next slide. Now, what happens down the road, and these are some of the things I've already alluded to, the post-concussive syndrome, where you're constantly having memory trouble. Or how about those daily headaches, which are miserable to treat, by the way. They're migraine-like, but they don't respond to the usual migraine medications, Imitrex and gabapentin and so forth. They're really difficult to treat. Cognitive impairment is also often associated with emotional mobility or neuropsychiatric problems. They're explosive. They have anger. They have temper issues. They're impulsive. Now they have mood swings. Their depression is 3 times worse. They're suicidal all the time. They run away from home. Maybe this might be more in an adolescent where they're all of a sudden running away. Can't do their homework or schoolwork anymore, dropped out of school. You can think of a bazillion scenarios. Okay? Epilepsy after trauma is very, very common. These are seizures that happen because of scar tissue or damage to the axons, and especially in focuses near the center of the brain, the hippocampus and the hypothalamus especially. Cranial nerve injuries. After concussion, someone can have a droopy face, they can get bells, they can have hearing trouble, where they get tinnitus, that ringing in the ears. They can get a little hearing loss, where they suddenly lose higher frequencies. What is tragic is a musician that gets a concussion and then they lose their ability of tonality. So they can't tune their instrument, they can't hear pitch. Especially for a professional musician, that can be a real problem. Or they're, man, geez, George, you used to play all the time and play by memory. Now you're off key, you're half a step off. I'm afraid we can't use you in the band anymore. So that's pretty tragic. Okay. And that's what I alluded to earlier, that depression, or that Parkinsonism, where now they have the shuffle gait and the mild tremor there. Really tragic to see it. You see that in severe brain injuries. We see that in some in our military, which our veterans don't really suffer from that. Okay, next slide. Last but not least, I think we're towards the end. Some field advice for you. If the patient or the observer said, "Oh, don't worry about it, it's just a bump in the head," and I get that a lot from the college athletes that want to be, Mr. Puffer, the seniors. They're in their senior year and they want to play so bad because they're going out with a bang. Oh, come on, doc, we're 7-0, and if we win the next 2 games, we're in the championship. It's just a bump. I'll be fine. But you were concussed. Please let me go back to practice. So keep that in mind. If they have a head injury and they meet criteria for concussion, we're going to have to insist they do not play until they're medically cleared. And that's a tough one. Even if we get a sign out on the field or at the court or on the ice rink, advise them not to go back to practice or play until they are medically cleared. If you tell them that, they agree, you write that on your run sheet, it decreases the liability on your end because if something happened and they come back and, oh, the EMS provider at the scene signed them off, but they didn't make mention of follow-up and the importance of not going back to play. So I don't want you guys to get in trouble or get hung up with that. Okay? Please insist that anybody with a loss of consciousness gets an evaluation. Hands down, I can't, sorry, Mrs. Smith, I can't have your son and you sign off on this because he did lose consciousness on the field. And most parents are with you on that. Most adults are not. Okay, next slide. So what do I do for a sign off? The observer needs to be with the patient if they sign off. Tell them these things. Tell them that if they start vomiting, if they act weird, if they start speaking abnormally, if they have a witness seizure, if they have anything that looks strange, sounds strange, smells strange, you take them to the emergency department. So just go overboard on your warning signs, sign them off, just in case. A lot of this may never happen if it's a minor bump to the head. 2 players, one player turns and the other player turns in the same direction. They bump. That's one thing. Ice hockey, they run into each other, and one checks the other, and they run into the boards, and the one player smacks his head against the board and then falls on the ice. Brief loss of consciousness there. If they want to do a sign off, make sure you warn them. Next slide. Educate. Oh, look at that. Everybody knows the history of that, right? And where that go. Pretty cool. So make sure you wear your helmet next time you dumbbell, you're out playing hockey and you're wearing your helmet. Shame. You were in a bicycle accident, you weren't wearing your bike helmet. Mr. John Doe, Mr. Hero, I'm 45 years old, I know everything about everything. Not wearing a helmet on the mountain bike trail and hit a root down the road. Had that happen. Inform everybody that works around you. This is a good education piece. So if any of you are asked to do an education thing for the 5th grade or the senior center or for the teachers as part of their conference gathering in the late summer before school starts, it's a good time to educate them and tell them your athletes should be wearing helmets. Make sure they wear their safety straps when they're on a go-kart or a side-by-side Make sure that they're helmeted with appropriate gear when they're riding a motorcycle and so forth. Bad things happen to good people. Okay, next slide. And everybody loves this word because that means you can take a bathroom break. We're concluding a substantial portion of our bad outcomes happen because we get a little cavalier or too lazy. Laziness can come from the patient themselves or family member or the coach or the athletic trainer. Nowadays, I've seen more athletic trainers and coaches be overboard cautious with head injuries than underneath, which is good to see. I'd rather have them send you guys and then you guys bring the patient to me and all of us say, oh, we're going to be okay. Rather than that second guess on the field or on the court. Prompt evaluation can mean a difference between bad outcomes and good outcomes. That's where we come into here. Don't forget low oxygen, low blood pressure, and low sugar are bad things. Okay, we treat those. Most of us in the room know that. Something to tell your greenies to your rookies. Make sure you tell the rooks, listen, make sure you pay attention. Never forget, vital signs are called vital for a reason. So don't underestimate the importance of a vital sign. And in that vital sign, include the point of care glucose. Very, very important. Okay? And isotonic saline, we've done that in. Next slide. Don't forget that a definition of concussion is a brain injury that's due to trauma, not a brain patient that's stroking. That's all the thing. So if they have memory issues because their blood pressure is 212 and they're drooping on the right side, that's not a concussion. Okay? And assess appropriately. I think that's it, except for my 100%. I got one of this. It's like, oh, I can do this now. So this is just an illustration of any kind of sport, including your children, grandchildren, nieces, and nephews on swings. Do children get head injuries on playgrounds? Absolutely. So don't forget that's a sport. You know? So playing in the sandbox, kind of a sport too, I guess. But don't forget our beloved Red Sox can get head injured, and I don't know what that says. Liberty on it. These are just stock slides. Yeah. So head injuries can happen. Even Ronaldo playing for Portugal, can get head injuries. So there you have it, head injuries in a nutshell. That way you're ahead of the game. Okay. Speaking of heads, bad joke, and then I'll let you take a break. A rope walks into a bar. Okay. Sits down, the bartender says, I'm sorry, we don't serve ropes at this bar. There's a sign. Dejected, he leaves. He waits till the next shift. He comes into the bar and sits down, and bartender goes, aren't you that rope that was in here a while ago? He said, yes. He said, well, we don't serve ropes here. So he leaves. He goes out and he pulls the top of his rope and ties himself in a knot. He goes back and he sits down and here's the rope that was just in here. And he says, frayed knot. With that move, you guys need a break. All right. Thank you all. Take 10.
All right. So everybody that's online, in the chat, I put in the link for the second hour. So you can go on ahead and go on over there. If you didn't already in this session, please put in your name and your EMS number so I can put you on the roster in the chat, please.
Make sure everybody signs the sheet.
So we have a second hour sheet also.
Yep.
This is the first.
That's the first one. And here's the virtual one. If you don't mind signing both sides of both of those, I think we got plenty of people here. Continue on it. I just have to.
That's the first hour.
So that's the second one.
How many do we have virtually?
16, 17, something like that.
Yeah. 16 also, we had 18 here.
Well, is that the first one? Yeah. Okay, got it. Tyler, I had him. Yeah. Edward, I had him.
See, I'll let you go. Yeah. Yeah.
Oh, really?
Yeah.
What?